everybody has to know what we're going to be injecting. So I'm just going to run around and basically tell you exactly what fillers are available and how fillers are different from one part to the other. So, and then you can make your own choices in which filler you need to choose. That's fine. Okay. However, this session is non-sponsored, so I will be talking about any type of filler. Okay, and you can ask me and I can tell you exactly which filler is good for which part. Okay, a brief history on dermal fillers. The first filler that was ever used... The first filler that was ever used was human fat. Human fat was used in the 1890s, and it was in a patient with tuberculosis, and which they took basically fat from one part of his body and injected it. So human fat is the first filler that was used. After that, paraffin was used as a dermal filler in the 1900s. What happened, however, is that patient developed problems when paraffin was injected into the body, and they developed paraffinomas. You've heard about paraffinomas. Then silicone became popular in the 1940s. However, of course, silicone has its own problems because it is considered to be a permanent filler. In 1981, bovine collagen was the first filler that was approved by the FDA, by the US FDA. However, because it's bovine, it means it comes from cows. It uses cow proteins or cow collagen. And it required an immunologic testing before it was actually injected. Cosmoderm, or human collagen, came after that. In 1996, the first HA dermal filler was approved in Europe and was launched then. This was Restylane. So Restylane is the first HA filler that was approved. In 2004, calcium hydroxylapatite was approved. Calcium hydroxylapatite is Radiesse. Then, during 2007, a lot of things started to happen, and Allergan was, actually started having Juvederm. And Juvederm is the first filler. Now everybody has lidocaine, but Juvederm is the first filler that was approved that contained lidocaine inside it. But now everybody across the board has it except Radiesse. And finally, in 2009, this is the new filler. I don't see it here in Egypt, but it's available, in many countries in the world, which is called the caprolactam. How do you inject fillers and where do you inject them? You have to know exactly which filler you're going to be using. There are certain fillers that can be injected in the superficial part. Other fillers are usually injected mainly in the mid to the deep dermis. So these are the areas in which fillers are usually injected. So what are we trying to achieve with fillers? What we're trying to achieve is that we're going to try to pump up some volume to achieve a youthful look. Now, what filler to choose? And this is the tricky part. This is the place in which I want you all to kind of listen. And if you have any questions, please let me know. Hyaluronic acids. These are the first fillers that, like I said, in 1996, the first filler that was approved was Restylane. Global sales, look at this, has jumped from 40 million in 2000 to 300 million in 2005. That was 7 years ago. I'm sure this number is much more than that right now. Over 80 companies worldwide produce HA-containing products. However, some of them are safe, some of them are not safe. So it's very important to know which company that you're dealing with. Where are we getting our hyaluronic acid? It can either be from roosters, or now it's basically from bacterial biofermentation. They stopped doing this in the avian rooster farms. Concentration. A lot of companies will tell you our filler is better than their filler because our concentration is... Where's my volume? Okay, our filler is better than their filler because our concentration is higher than their concentration. This is absolutely wrong. Okay, so it is false to actually say that. You have to know what filler you're going to be dealing with. And I'm going to show you how. Fillers, any filler, especially the hyaluronic acid, if they are not cross-linked, then you have a problem. What is cross-linking? Cross-linking, this is how an HA looks like. It looks like a powder. What happens to it is that they add a little bit of water. It becomes an uncross-linked HA. If you inject this into the skin, what happens to it is that within 2 hours it goes away. It does not remain. However, it has to be cross-linked. And the cross-linking that they use is BBBE. This cross-linker puts the filler, creates covalent bonds into the filler itself, and makes the filler a little bit more stabilized. Does not allow the filler to become hydrolyzed. And then this is how it looks like. So, fillers are usually divided into non-particulate fillers, which are monophasic, and particulate fillers, which are biphasic. The non-particulate fillers, examples of them is Juvederm. Juvederm is a gel. Okay, it is a non-particulate filler. Here, for these, the monophasic one, the concentration is important. The higher the concentration, the thicker the filler, okay, the longer it will stay. But you cannot compare non-particulate fillers with the particulate fillers, because particulate fillers have to do with size of the particle. They have bigger particle sizes and smaller particle sizes. This is Restylane. So the people from Juvederm cannot say our product is better than Restylane because you're comparing apples and oranges. Okay, they're completely different classes of hyaluronic acid fillers. Now, Juvederm can compare itself, for example, with QCL because it is also monophasic, but you cannot compare those other two together. Okay, so keep that in mind. Elasticity or G prime, this is an important thing. This has to do with the capability of the filler to withstand outside forces. The higher the G prime, the more lifting effect that the filler has. If you look at this, I don't know if it projects very well. It's fine. Yeah, calcium hydroxylapatite has the highest G prime, meaning it has the highest lifting effect. Okay? Then you have the Restylane group, and then you have the Juvederm group. People are going to say, so Juvederm is pretty low, so it doesn't have a very good lifting effect. No, it is not as simple as that. Because Juvederm is a gel, not a particulate filler, the cohesivity of that gel allows it to have a lifting effect. Even though the G prime is low, but the cohesion, because it's a gel, provides that lifting effect. Okay? That's the reason you cannot compare this and this, because this is a particulate and the other one is a non-particulate. Does that make sense? Yeah. Okay, good. Let's look at the lines that we usually have. Restylane, this is the first one, 1996, as I said. In 2010, 11 million treatments worldwide were performed. In 2010, Humid was acquired by Galderma for $1 billion. They bought them for $1 billion. In the US, it is the first HA filler approved by the FDA, and that's basically how it is. This is how it looks like. Look at this. This is the Restylane Vital, which is the thinnest type. Then you have the Restylane, then you have the Parylane, and Sub-Q, and then you have the Macrolane, which is used for the body. Look at the surface. The surface here is very smooth because the particles are very small. Look at this. 500,000 in 1 ml compared to the others. This is 100,000 for Restylane. This is 10,000 for Parylane. And you can see the surface becomes much more coarse as you get larger and larger because this is a particulate filler. Macrolane, of course, I don't know if it's available here in Egypt, but it's usually used for body enhancement. It takes about 30 to 90 minutes. You could inject anywhere except the breasts. In 2012, the Vedas signed an agreement not to inject it. It lasts for about a year, and it has had a few problems. Allergan, this is what they have. Allergan was in 2000. That's what was first approved in the EU market. So it came 4 years after. In 2007, Allergan was acquired Innomed, which is the French company that makes Juvederm. And it is the first HA filler that contained lidocaine. However, all of them now contain lidocaine. All of them, I know, actually. This is how it looks like. This is Restylane, which is the biphasic one. Look at the surface. And look at the surface of Juvederm. Okay? This is a little bit more on the smoother side. This is microscopically also. Okay? And because this is a particulate filler, this is more of a monophasic filler. The most important one right now that everybody's talking about is the Voluma, which is mainly used as a volumizing agent. Teoxane. This is an interesting story which I don't want to get into, but the people from Teoxane actually used to work for the French company that produced Juvederm. They do have a number of fillers that are approved. Worldwide in sales, it is the third place HA wrinkle filler. Allergan comes first, then you have Galderma Humid comes second in terms of sales, and finally, the QCL comes into the last one. This is their line of product that they usually have, ranging from the highest, which is basically the ultimate, comes in at 3 ml, all the way down to the soft line. Calcium hydroxylapatite. This is a different class of fillers right now. We're not dealing with hyaluronic acids anymore. This is a biostimulatory filler. It was approved in EU in 2004, FDA in 2006. Bioform acquired by Merz Aesthetics. So that was actually made by Merz Aesthetics, which is a German company, for $250 million, which is basically very cheap compared to how much Galderma paid for Humid. What is it made up of? It's made up of calcium hydroxylapatite and gel carrier. 30% by volume is calcium hydroxylapatite, 70% is the gel carrier. How does it look like? This is a white product.
tell my patients, because it contains calcium, think of what contains calcium at home. And a lot of people tell me, oh, you know, milk contains calcium. I know milk is white. Okay, so it looks very similar to that. Some people mention teeth, some people mention bone, but all of these are usually white. So just, you know, the whitish one, the whitish filler is calcium hydroxylapatite. This is how it looks like. These are made up of microspheres, and this is how it looks like microscopically. How does it work? It works basically by injecting the filler inside. The blue is the gel, the white is the microspheres. What happens is the microspheres stimulate the fibroblasts to produce collagen, then the microspheres disappear by the effect of macrophages. Polycaprolactone, you guys, this is not available here, but it's very similar to calcium hydroxylapatite in terms of theory. It comes in different forms, but it works the same way. It comes in a gel, and at the same time microspheres. The gel goes away, microspheres stay, and then it goes away completely. This is how it looks like compared to, for example, Sculptra. This is Radiesse, and this is the polycaprolactone, which is Elancet. How do they work? This is how they work, both of them. When you first inject calcium hydroxylapatite or polycaprolactone, the initial volume that's provided is mainly by the gel. With time, the gel goes down, and the microspheres pick up, and then you have your own collagen that's actually creating that volume. So at one point in time, there is going to be a dip. If you're using Radiesse, a lot of your patients will come to you, for example, after 2 to 3 months saying, oh, the product is gone. That's normal because the gel is going away. The collagen still has not yet completely filled out. Okay? And during that time, you can actually touch them up just a little bit, just to make them feel a little bit better. So I usually see my patient about 3 to 4 months after that. How do you do that? I'm going to show it to you practically. This is how we do things. You draw in a little bit of lidocaine for your calcium hydroxylapatite. You connect the female-to-female connector. Put the lidocaine into the female-to-female connector to get rid of the dead space. Okay? And then connect your calcium hydroxylapatite. This product does not contain lidocaine, so it has to be premixed. This is the way to premix it with lidocaine. And then you go back and forth about 10 to 15 times to get a homogeneous material. The solutions that we use, I usually use 20% of the volume. So if it's 1.5, then I'm using 0.3. If it's 1, I'm using about 0.2. Now we're going to look at before and after pictures, and we're going to start off with our live demo. This is a before picture. This is the after. Treatment just of the cheeks. The mid-cheek was actually treated. Nothing, though the tree trunk was not treated, no other nasolabial fold was treated. It was just the mid-cheek area that was actually treated here. This is another patient. If you look at this, about 10 units of Radiesse was actually injected. It's 15 ml of Radiesse that was actually injected. This is a patient of mine. These are all. Can you not take pictures here? I don't want to take pictures of my, because these are patients' pictures. So please don't take pictures of these, of the ones that I'm going to show you. Take pictures of the presentation, but not the pictures now, please, of our patients. So this is a patient here. What happened basically is that we injected her with 15 ml, and you can see it provided that. Are you taking pictures? Hello? No pictures, please. I just said that, no pictures. Okay, so as you can see here, without treatment of the nasolabial folds nor the tree trunks, you have achieved what I call a liquid facelift. So you provided basically a non-surgical approach to get from here to here. This is immediately after. So there's no bruising, nothing of that sort. And the patient basically just goes out and she can go have dinner. This is how she looks on the side. If you look at the neck, she's got a little bit of extra skin here. Look at it here, it's completely gone because you've actually fixed the chin area. So it's very important in that sense to look at a patient on the global side. Nasolabial folds gone, cheek tufts are also gone. This is another patient. If you look at her, no treatment of the nasolabial folds. If you see these patients, everybody will say, let's treat the nasolabial folds. No, that is not correct. You treat the cheeks and look at the nasolabial folds and look at the cheek troughs. A little bit of Radiesse, that was 4.5 ml of Radiesse injected in these areas, completely helped this patient a lot. This is another patient. Okay, this is another patient who came to me and who only wanted her nasolabial folds to be treated. I told her, no, you need the mid-cheek area to be treated. After treating the mid-cheek, she looked like this. This is how she looked immediately after. She did not like the way that she looked because she came wanting the nasolabial folds to be done, and I did only the mid-cheeks. And she told me, like, Doc, I don't like the way that I look. I told him, give it some time. The whole point of this is that after 2 weeks, when she came to visit me, this is how she looked like. So a lot of these products, what they do, or what happens to them is that they are going to expand. Okay, because they swell up just a little bit. So never ever overcorrect your patients. Always go for a one-to-one correction, or maybe undercorrect, and see your patients after 2 weeks if they needed any touch-ups. Okay, just be careful in that sense. Do not overcorrect your patients. I usually tell everybody in my audience is that when we first started learning math, we learned addition before we learned subtraction. So it's much easier for us to add rather than for us to take away. Okay, so keep that in mind. This is another patient who treated the tear trucks. This was a product known this is a 2CL product known as Redensity 2. So you can see here the differences between here and here are significant. Injecting the nose, I usually use calcium hydroxylapatite. And as you can see here, I'm using a cannula, and I'm just going straight into the nose depending on the area of the defect. This is how before and after pictures. This is a patient who's got a little dip on her nose, a little bit of calcium hydroxylapatite, 0.4 ml, and the nose becomes on a straighter side. Some people actually want their wrists to be enlarged. I don't know, maybe you've seen them here in Egypt, but this is how they inject the wrists. It's very similar to injecting the hands. So you put a little bit of radius maybe on the wrist area. This is Macrolane. A lot of people are going to ask about Macrolane. Can you guys see the difference between this chest over here and this chest over here? So this is a patient who comes in who wanted his chest to become bigger. I don't know why. He's got other issues going on, but he wants to look, he wants to look muscular. So we've injected Macrolane mainly on the chest area. So about 120 ml of Macrolane mainly was injected in this chest, and a little bit in the biceps area. You can see his biceps have gotten a little bit bigger. Okay, so this is not real. So a lot of people who you see probably out there who look muscular and so forth, maybe that's not real muscle. Okay, so it's mainly a little bit of Macrolane. This is the same patient on the other side. As you can see here, this is the areas of injection. You can see the curve that's produced by the injection of Macrolane. The nipple has changed. If you look at this, the nipple has kind of gone down here, and after that, the nipple has kind of like contoured in, as if the patient has muscles, so has basically a good pectoralis major muscle. Also, the biceps have also been enlarged. Level of injection, you're on top of the muscle. You're not underneath the muscle, you're on top of the muscle. Okay? Alright. So final words of advice. Do not use products that do not have an appropriate safety record. A lot of companies out there are going to tell you our HA is cheaper than, for example, those other HAs. Okay, don't go for price. Okay, go for quality. Go for companies that have had a track record, that they've done studies, safety studies, that looked at how patients actually reacted, how are they doing. Okay, so cost should not be an issue for you. So try to really not to think about that. Be aware of anticoagulants intake before injection. So ask your patients if they're on aspirin, if they're taking, for example, any warfarin or so forth. It's very important to know these things, because even though you could inject them, if they do end up bruising, the bruise is just going to take longer for it to go away. Use the smallest gauge needle possible. If you have a patient that has, that you want to use, for example, Restylane on, don't use a 25 gauge needle. Use a 30 gauge needle, okay, or a 29 gauge needle that's provided. But don't use something that's big. The bigger the needle, the more chances of you developing bruising. Use the appropriate filler in the correct area. This is also important because, for example, if you want to inject the lips, you are not going to inject the lips with Radiesse. You should not inject the lips with Radiesse. You can inject it with Restylane, you can inject it with any HA. Okay, but you do not want to inject, for example, the lips with something that's thick. Okay, so know exactly, because there's a whole range of these fillers. Know exactly which filler should fit in which area to be used. Inject the material at the correct level. If you inject it too superficially, you can get lumps or bumps. If you inject it too deep, okay, then the filler might go away. It goes away very quickly and you require more volume. And the patient, it costs more for the patient. Ice the injected area before and after treatment. I don't use any blocks. Okay, I don't even use Emeline. Okay, and no topical anesthesia. I just go straight ahead and inject my patients. And most of the time, they usually don't feel any pain. Okay, and it's because of the ice. You put a little bit of ice immediately remove it, and then start injecting. And the patients are not going to feel anything. Massage the treated area. Always, always, always massage. After you're done, you need to kind of contour the filler. Okay, a lot of these fillers, once you get injected, they might kind of conform just a little bit, so you want to make them a little bit more on the smoother side. So always massage it. Avoid overcorrection, and I mentioned that. Do not overcorrect your patients. Okay, always undercorrect or go for a one-to-one correction. And finally, take your time. Okay, I know you probably have a very busy clinic. Okay, there are probably maybe 30 patients waiting outside, and this is a patient who comes in, you just want to finish up very quickly so that they go away. But take your time. These patients come here, they came to see you, they want to look good. Okay, and they are actually paying the money for it. Okay, if you are rushed, or if they feel that if you're rushing them, then they feel like, oh my God, what's going on here? Consider this like this. When a patient comes to you, like a woman comes to you and she wants a filler to be done for her, it's like her going into a Louis Vuitton store. Okay, she's taking her time, you want to pamper her. Okay, that's the reason why you have to take your time with these patients. There are different set of patients than, for example, your vitiligo patients or your psoriasis patients or anything like that sort. Those other patients have a disease. They're here because of medical condition. Your patients here, they don't have a medical condition. They came here to look good. Okay, so you have to make them look good. So you want to take your time to make them look good. Okay, don't tell them, okay, you need this, this, and this, pop, 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 and I'm gone. No, so you really try to tap it. There's a lot of hand-holding, tender, loving care. Always be nice to them. Okay, so it's very important to know these little clues. Thank you very much. We are bidding for the World Congress in 2019 to be held in Dubai. So if you know your societies, please tell them to actually vote for Dubai in Vancouver 2015. All right, what we're going to do is we're going to move to the other side right now. So if we can have the lights open. Can you have the lights open, please? No? Nobody wants to open the lights? Any questions? Yes. Most of the time you're a little bit on the deeper side. If you can see the needle, if you're injecting and you can see the needle trapped there, then you're superficial. Then you need to come out, and then you have to inject it. What I usually tend to do is that there are three. There's not the slide here, but there are three things that you have to take into consideration. If you see the needle, you're the superficial dermis. Take it out, put it in. If you put it in and you don't see anything, there's no lift at all, you're very deep. If you are injecting it, but you don't see the needle, you don't see the color of the needle, but you see a little bit of a tint, okay, then you are in the dermis. Okay, that's the area where you want to inject. Okay? But now, recently, with all the advances of fillers, most of our injections are a little bit on the deeper side. We're injecting in the fat compartments. And you're going to see as we're going to start injecting all patients, we're going to be injecting mainly in the fat compartments. Okay? Yes, another question.
Like, say, exactly when you inject that, you get resistant dermis. No resistant of me.
Yeah, that's true. That's true. But also, the resistance also has to do with your needle size, whether your needle is too big, too small. So I mean, if you're injecting, for example, a 25 gauge needle, and you're putting it in the dermis or in the subdermis, it's just going to flow very easily. It comes out, the filler material comes out very, very quickly. So it really has to do a lot with the needles. But you're absolutely correct. Okay?
Yeah.
Okay, let's
Please, what should we inject the needle or the cannula? At the beginning.
I'll get to that. Okay, so
There are these injecting epidermis, isn't it?
the upper dermis? No injection should be done in the epidermis. Yeah, most of the injections should be done in the mid-deep dermis or even subdermis, but never in the upper dermis. If you inject a hyaluronic acid, this is a good point. If you inject an HA in the superficial dermis, you are going to develop what we call a Tyndall effect, okay, which is that blue effect that happens. It's not a bruise. It's the way that light reflects on the skin once a gel is injected. So do not inject it in the superficial.
So there are this injecting the epidermis. How you know that the needle is in the epidermis?
I just explained it.
If you see the tint of
Usually you see the tent, yeah.
If you see nothing, you are very deep.
You're very deep, exactly.
That's right.
That's the way. If you see the needle, if you see the metal of the needle, then you're very superficial. You have to knock it. All right, let's have. There are two questions. I'm going to answer the three questions. Okay, so let's have 1, 2, and 3, and that's it.
I want to ask about
Yeah.
about cross-linked HA
Yes.
for music therapy, like Restylane Vital, which is injected all over the cheek.
Right, right.
What do you think about that?
Okay, so all right, that's a good question. There are many new products that are coming out. They're known as the mesotype products, or they're injected in a meso effect. If they are cross-linked, they work. But if they are not cross-linked, because there's like 20, 30 probably non-cross-linked products that are out there, and they usually come in liquid form. These are the non-cross-linked HA, which they use the gum for. Okay, those really don't work. Okay, but the cross-linked ones actually work, and it has been shown. I mean, we're not talking about just industry or company studies, but it does definitely work. So Restylane Vital is a meso type of HA that's injected, usually in the superficial mid-dermis, to provide a little bit of a hydrating effect. So it's hydration, not volumization. Okay, so but it definitely works. Yes.
Sometimes it fillers cause organs edema that lasts for a few days. Is it because of the filler itself, or because of the patient, or what's
the mechanism? Alright, so there's something called hygroscopy, okay, which is the filler's capability to absorb water. There are different fillers that are actually much more saturated compared to the others. For example, Restylane is much saturated compared to Juvederm. If you inject Juvederm, okay, you are going to get more swelling in Juvederm compared to Restylane. Okay, this is a common fact. Okay, it's because the Juvederm absorbs water more. Okay, so it's the ability to absorb water. And remember, hyaluronic acid is like a sponge. So it just absorbs water. That's why you get these swellings that usually happen.
Sometimes they both in one patient and both in another patient.
Right, and so it's different from one person to the other. I can't really explain that. I mean, it's the same thing as like, some people have acne and other people don't have acne.
Yes, patients, what's the management?
What is the management? It's usually time. I just tell them if it's edema that happens 2 to 3 days, just tell them, give yourself some time and it goes away. It takes about maybe a week, but it definitely goes away. If it doesn't, then we have a problem.
The durability of most of the fillers nowadays is very short, for three months. Is it because of also the fact of filler? Sorry.
No, okay, so the durability and the longevity of the filler?
I noticed that the fillers doesn't last for the appropriate period.
No, I mean, usually, for example, Restylane, Perlane usually lasts about 6 to 9 months. There has been a study that showed that this was published in Dermatology Surgery in a group of patients in which Restylane was injected in the first time. Then after 4 months, it was injected again, and it showed that it actually lasted for 1.5 years, 18 months. Okay, so I mean, it all depends on how you inject it, how you bring your patients. If you inject too deep, it's going to go away very quickly. So that's it all depends on that. All right. Okay, one last question, and then we're going to start injecting.
If you are confronted with a patient who has injected since 6 months or 4 months, are you worried about the type of filler?
Absolutely.
She doesn't know about that.
No, if she doesn't know what filler was injected, I will not touch her. I will not touch her unless she's my patient and I know what filler. But I will not touch her. There are a few patients that I usually don't touch. One of them is this. Okay, it's a person who comes in from I don't know what, she doesn't know what she's injected. Okay, and she wants me to inject her. That's patient I do not touch. That's one thing. Another patient I don't touch any other person's complication. Okay, so if you develop any complications or anyone in the audience developed a complication and you referred your patient to me, I will tell that patient to go back. Okay, go back to you. Okay, because I don't know what to do with this complication. You created the complication, you treat the complication. Unless I know what type of filler was injected. If, for example, if it was Restylane that was injected, and you don't have hyaluronidase, and you refer the patient for me, then yes, I will inject hyaluronidase. But if I don't know what filler was injected, you inject something, they're not going to blame the first doctor, they're going to blame you. Okay, so don't do that.
So about lidocaine,